All right, we're live. Hello, web shadowers. Thank you all for attending our session this afternoon. Today, we have the pleasure of hosting Dr. Spessot, who will teach us about psychiatry. As always, please remember that the Google form will be posted in the chat box in the description of the video. With that being said, Dr. Spessot, you may start whenever you're ready.
Hello, everyone. Before I start, I would like to just take about 10 seconds to breathe and to ground myself. And so I would invite you all to do the same. All right. Well, I can't see your faces, and so that's a little weird, but I am so thrilled to be here. It is such a privilege to be able to address a group of future physicians. It's always exciting to know that there are people who are entering into our profession and who are excited about our profession. My first take-home point for today, if my screen moves, is that there is always time to breathe. Always. So your mind is going to trick you into thinking that you have to do what you have to do right now, and there's not even a second to take a break, but that is not true. I'm here to tell you that even in the most emergent moments in the practice of medicine, there's always time to breathe. Is there a 10-second period for you to ground yourself? Maybe not, but there's always time to take a breath, and your survival depends on it, literally. And also, you will be a better doctor for it. So I was asked by web shadowers to start this presentation by talking a little bit about my field of specialty and a little bit about myself, an introduction. And that is a bit of a loaded question to ask to a psychiatrist, but I'm gonna try my best. Another thing to know is that I did not rehearse this this presentation. When I give talks like this, I just prefer to speak from the soul, if you will. So what you're getting is going to be me, being spontaneous at the cost of maybe a little organization, but it's a trade-off. So who am I? I decided to use some pictures to illustrate who I am, and I picked these two places. The picture on the left is a small town called Biran, and it's now in Slovenia. But when my parents were born there, it was Italy. And after World War II, both of my parents fled Biran, and they immigrated to the United States under duress. And my mother came as a refugee to the United States, and my father came as an undocumented immigrant. And this is really a critical piece of my background because really being a first-generation American has framed who I am as a human and who I am as a physician. And to me, I grew up with the with getting constant feedback from my family that achieving one's dreams is important and risks can and should be taken to achieve one's dreams. And so I have taken that with me, and I always pass it along. And so my parents settled in Brooklyn, New York. And so that's the picture on the right. And that's a neighborhood called Bay Ridge, and it's where I grew up. I left New York for the first time to go to college, and I went to Johns Hopkins. And at that time, I thought that was going south because, it was below the Mason-Dixon line. And so I told everybody I'm going to the South for college, but it was in Baltimore, Maryland, not as South as I am now. But anyway, at Hopkins, I studied international studies and sociology, and I minored in Italian literature. And I thought I wanted to be a lawyer. And that was all, well and good until I graduated from Hopkins and realized that I actually didn't want to be a lawyer. I wanted to be a doctor. And so at that time, I enrolled in the post-baccalaureate pre-medical program at Columbia University. And I stayed on at Columbia and got my medical degree from the Columbia University College of Physicians and Surgeons. So my next take-home point is it's okay to change your mind. You all are presumably at the university level, studying the sciences, wanting to go to medical school. You may or may not choose to do that after graduation, whatever you choose, it's okay. I am here to tell you that you do not have to have it all figured out. You can figure it out as you go, and you will be fine. Better than fine, you will be great. So I left New York City. I was almost 30 years old, and I didn't imagine I would ever leave New York City, but I did because North Carolina is warmer. It costs less to live here. There are trees. So that's the picture in the middle. And who I am today is like all of you. You know, I'm a multifaceted person. On the left is me as a mother. I'm a mother. I'm a husband. I'm a wife with a husband. And on the right is a picture of me in one of my roles as a medical director in community mental health. And really, if you were to ask me career-wise, you know, who are you? I would say that I am a physician who is dedicated to alleviating human suffering from mental illness. Really, that's my why. That's why I get up in the morning. That's why I do what I do. It's why I work with patients. It's why I do administrative work. And it's why I give talks like this. So next I was asked to explain a little bit about psychiatry. And so the definition from the American Psychiatric Association is that psychiatry is the branch of medicine focused on the diagnosis, treatment, and prevention of mental, emotional, and behavioral disorders. And I just think about it as where the brain meets the mind. Really, it's just this wonderful combination of neurology, general medicine, and also psychology. And it's beautiful. It's a way of really getting to know people very intimately on the inside. And it's interesting because a lot of psychiatrists I know almost became surgeons, myself included. And a lot of surgeons I know almost became psychiatrists. And I think that it's because those are two specialties where you truly get to see people on the inside. So that is why I chose psychiatry. Does anyone at this point have any questions about psychiatry or about anything that I have said to this point? Okay, I see no questions yet. Excellent. So what I want you to get out of this talk is the idea that process is oftentimes more important than content. So if you go to medical school, you will get there and you may have this overwhelming feeling, fear even, that you have to know everything and learn everything in those 4 years. And the truth is that you will get to medical school and you will learn a lot, more than you could ever imagine learning in your whole life, packed into 4 years. But when you're a million years out like me, a lot of that will be obsolete. And so, that's why God invented continuing medical education, CMEs. We're always learning as physicians, always learning new things, always keeping up to date. But a lot of what you actually learn in medical school will be obsolete. But what will never be obsolete is the critical thinking skills that you get from medical school. If you allow medical school to teach you how to think about the patient before you, you've learned what you need to learn. And that is so, I can't state it enough, and I probably will state it many more times in this talk. Process is more important than content. And it's really how you approach a case and how you think critically about a case that's super important. And so that's actually why I chose this case to present to you, because it really wasn't what I would call my, bread and butter as a psychiatrist. And I think you will soon see why. So the case study that I chose is of a 19-year-old man who presents to a behavioral health urgent care setting. I have omitted some identifiers. I've modified some identifiers just to completely preserve confidentiality. But this person presented to an urgent care setting that's specific to behavioral health. And his chief complaint was, I'm struggling so bad with my anxiety and disconnect, and I'm just so scared about the future and what's going to happen to me. Really important clinical pearl in psychiatry, but maybe in other fields as well. Always use the patient's own words as much as possible. So think about where you are documenting this information, right? In the medical record, it's probably electronic, although it wasn't when I was training. It's going to be in the medical record. It's 2D, right? You're going to be, the next person is going to read your note and they're going to, see this information. It's going to be presented in 2D. But when you use the patient's own words, suddenly it becomes 3D. Suddenly you're painting a picture of the person. And it really allows the person who's reading it after you to almost, be part of that interaction. It really gives a different feeling. And this is so important in psychiatry in particular, to really characterize the person in front of you as best as you can. And so in my experience, one of the best ways to do that is to actually use the patient's own words. So some background information, initial information. The patient's accompanied by his father, and he asks that his father remain in the room. The patient has a past psychiatric diagnosis of attention deficit hyperactivity disorder, but he hasn't been in treatment with a psychiatrist since his early teens. He's not taking any medicines for ADHD. This has not been a particularly contributory illness for him, to his history and current presentation. He has no other psychiatric history. He has no medical problems. He doesn't take any medications. He has a remote history of allergy hives with penicillin. He is a high school graduate. High school was uneventful, fairly typical, really. He got good grades. He really enjoyed school, played sports, did other activities, had friends, full social circle. His parents have been divorced for a number of years, but it is an amicable co-parenting arrangement, and he's currently living with both of them, intermittently, spending some time with one, some time with the other, and he is attending virtual college to his dismay because of the pandemic. So what are his presenting symptoms? Again, I'm using his own words as much as I can to really give you a picture of this person. He tells me that he is just in constant fear. He's experiencing such severe anxiety that I'm completely unfunctional, he says. He says, there's just this looping in my head where I'm just always thinking of the worst case scenario. And so in my interpretation, he's talking about anxiety, and that's manifesting as feelings of nervousness, feelings of impending doom, ruminative thoughts, sort of thinking around things over and over and over again, psychomotor restlessness, and also trouble concentrating and formulating his thoughts, losing his train of thought. He was not overtly suicidal. He was not saying, I want to kill myself. I'm thinking about killing myself. I have a plan to kill myself, or any intention of hurting myself. But he said, I'm just feeling so hopeless. He was increasingly hopeless and, also agitated and anxious. he also was describing a feeling of disconnect. He said, reality just feels so weird, it's so different. And he described feeling disconnected from himself and from his thoughts, and said, really, I don't feel anything except anxiety. And last but not least, he said that he was experiencing visual snow, and he called it that. And so I have an idea of what that is. I knew what that was, but I also like to ask people what their perception of when people use medical terms with me or some kind of jargon with me. I don't take it, for granted that our understanding is the same of that term. And so I asked him, what's visual snow like for you? And he said, well, imagine you're looking and it's like a layer of TV static over everything that I see. Any questions for me at this point? Oh, this is great. These are great questions. I am going to answer one of these now and then hold some of these to the end to a sort of broader discussion. Do I think the brain is different from the mind? I think the mind is the manifestation of the brain. I think, what is happening in the brain manifests as our experience of the mind, if that makes sense. I hope it makes sense. And then there are a bunch of questions about actually choosing my field and managing my own mental health. And so I love those questions, and I'm going to save them till the end. So in psychiatry, our exam is called the mental status exam. And so we do, of course, pay attention to people's physical health. We always look at, vital signs and other, physical indicators of health. But the real, the meat of the psychiatric examination is called the mental status exam. And so I am going to go through the mental status exam a little quickly, but I'm happy to answer, questions. And I may have some questions for you about the mental status exam. So this man's appearance, he is casually dressed, he's appropriately groomed. I'm going to want to look at, is he dressed appropriately for the weather? Is it 80 degrees out and he's covered in blankets, or is it really cold and he's in shorts? What is his appearance like? Is there anything specific that I might comment on about his appearance? Are his clothes torn, or really whatever stands out to you as, how this person looks, to, again, really paint a picture of who this person is. That's what should go in appearance. Of course, setting matters, and the amount of time you have matters, and I'll get to that later. And so in this case, I wrote, he's casually dressed, he's appropriately groomed, his behavior was calm and cooperative. The psychomotor exam looks at whether you notice any obvious tremor or any other abnormal movements like tics or other stereotype movements. I noticed that he was fidgeting in his seat a lot. He seemed sort of restless. And so that is what I would refer to as psychomotor agitation. His speech was fluid. It had normal rate and rhythm and prosody. And he characterized his mood as anxious. So mood is, when you ask people, what's your mood? What they say is their mood. And so mood is characterized as, the person's own words. What's your current mood state? He says anxious. Affect is the manifestation of mood. And so if he had told me he was anxious, but he actually appeared relaxed and was joking and laughing, I would say that, his affect was inappropriate to mood or incongruent with stated mood. In this case, his affect was appropriate to his stated mood. He actually appeared to me to be anxious. And also the range of his affect was constricted. And so in psychiatry, when we address affect, we want to talk about whether it's appropriate to the mood, any other descriptors for it. So his affect, I would describe as anxious, but also the range. And so is he able to experience, is there evidence that he's experiencing a full range of affect? So even though he's predominantly anxious, did I see him lighten up, a little bit at different times? Is somebody who comes to me whose affect is tearful, do they also have moments where they are, calm, or where they're able to smile or joke? So that's what range of affect is. And in this case, he was just anxious, constricted range. It was just that one thing, which was very congruent with how he was describing how he was feeling. Thought process refers to whether the person can follow the conversation and participate in a linear and logical way. And he could. Now, his thought content, some of the statements he was making to me were maybe a little bit strange sounding to me. And, in psychiatry, we use the term bizarre. And he said some things like, I'm trapped behind my eyes. That may have just been how he would sort of normally, speak. So I don't really know his baseline, right? But it also may have been something a little unusual that might be reflective of a, of an underlying process. And so I took note of that. But I also made sure that he was able to test reality around those thoughts. So can anyone tell me what I might be referring to here? This is kind of a guess what I'm thinking, but when I'm talking about being able to test reality, what does that mean? Does anybody know? Anybody want to chime in? Ooh, sorry. Okay. I'm assuming, goodness, I keep pressing the wrong thing. Okay, how mood and affect could be incongruent. So what I'm getting at here is the concept of a delusion. And what a delusion is a fixed, firm belief about the world that is typically unusual by definition. And so a delusion might be paranoid if somebody's saying, I think that the CIA is out to get me. The CIA is following me. It could be what's called a somatic delusion, like a delusion of being sick. And what I mean by being able to test reality is, can the person imagine the possibility that it's not true? And so what I asked him was, so I said, you're saying you feel trapped behind your eyes. Are you able to entertain the possibility that that's not actually true? So if this was a delusion, the person would say, no, that's definitely true. Like the CIA is definitely following me. I'm definitely being, targeted by, the person down the street. There's this idea of a fixed and firm belief, and it doesn't waver. But if somebody's able to test reality, they're able to say, well, I do think it's true, but I guess it's possible that it's not true. And in this case, I was asking him about what he was saying. You're talking about feeling trapped behind your eyes. Do you think there's any, potential explanation for this? And he was like, oh, definitely. I definitely think that this is part of what's going on. It's not real. It's just kind of the way I'm conceptualizing it or like feeling it, but I know that it's not real. And that to me is very important, because that then by definition is not a delusion. He's able to test reality around his strange thoughts. And so that to me is reassuring. So perceptually, I want to look at, is he seeing things that other people can't see? Is he hearing things that other people can't see? Is he feeling things like having a tactile disturbance that other people can't feel? Or is he smelling things that other people can't smell? And so he is having some visual disturbances that other people are not experiencing. So he's having perceptual changes. He's seeing this visual snow, but he's not having any other kinds of hallucinations. There were no concerns that he would be potentially harmful to himself or to other people. Cognitively, he appeared grossly intact. I didn't do any formal cognitive testing with him, but I wasn't worried that he was limited or impaired cognitively in any way. And he did show fairly good insight and judgment into his condition. He's an adolescent, and so there is an age-appropriate determination also that gets made in psychiatry. You know, did I feel at his stage of development that his level of insight and judgment was appropriate? And yes, I did. So now is another good time to ask if anybody has any questions about the information that I have presented so far. Okay, yes. So one of the questions is, how could these kinds of hallucinations manifest, and how would you pick up on them and address them? And so typically, oh goodness, sorry about that. I missed this. I lost my screen. How you would get at perceptual disturbances is the first thing you do is ask. And so that's the more direct way. And so if somebody you will ask, are you hearing things that other people can't hear? Are you feeling things in your body or on your skin that other people probably aren't feeling? Are you smelling anything that other people can't smell? Now, sometimes people will be experiencing these things, but for any number of reasons won't want to disclose them, won't choose to disclose the information. And so in that case, there are sometimes other tells that somebody's experiencing hallucinations. And so for an auditory hallucination, you might notice that the person is just literally looking around the room, darting their eyes, even if their head isn't totally moving, their eyes are moving as if they are interacting with something that you can't, see or hear. They are not seeing that thing, but they are hearing it as if it's another entity in the room with them. If somebody is having olfactory hallucinations, they might be sort of reacting to the environment in a way that is not predictable, and the sort of alluding with their, facial expressions and knows that they are, smelling something. And tactile hallucinations, similarly, they will usually appear to be in some kind of distress, or they might be scratching or moving as if uncomfortable. And if somebody is having visual hallucinations, similarly, they will be focused somewhere that you would not think they should be focusing. They might be looking in the corner of the room or looking all around, where you would have the suspicion that they are seeing things that you aren't seeing. Yeah, would you be trying to figure out if the patient has a psychotic disorder in which patients have false beliefs and perceptions? Yes, absolutely. And so I am always going to be looking for signs and symptoms of psychosis. And so that was on my differential diagnosis here, because he was telling me that he was seeing things that other people, weren't seeing. He was also making these unusual types of statements that could have been delusional. And so it was on my radar for sure. However, what I would also look for in somebody who has psychosis is whether they were able to follow a conversation and whether their thought process was organized. And his was very organized. He was linear, he was logical. And so after my overall exam, my suspicion for psychosis was low, but certainly it was what I was considering, one of the things I was considering at the time. So the next take-home point is setting matters. And so before I ask you what other questions you would want to ask of this person to figure out what was going on, it's really important to consider what the setting is. In an urgent care setting, imagine that I have a waiting room full of patients needing to be seen, and I have really never seen any of these patients before, so they're all new to me. Most of them don't have previous history in that institution, and so my ability to access previous records might be limited. And I really have one main choice to make, and that is this person safe to go back home, or do they need a higher level of care? So that is a primary decision. It's sort of the fork in the road. It's the first thing I have to kind of figure out. And then in addition, I then have to, go on and get an idea about what's going on and how to proceed with treatment. So in the context of an urgent care setting, what would you want to know additionally about this patient, apart from what I have already told you? Any ideas? Okay, well, I'm not seeing any ideas, and if that, I apologize if there's a lag and I'm missing that. But I'm going to tell you some of the questions that I asked. This is not comprehensive in the interest of time, but I'm going to give you a sense of where I went with this. Oh wait, there's something in the chat. Yes, family and personal history of psychotic disorder and a history of self-harm. Great. No family history of psychotic disorder, no personal history of psychotic disorder, and no history of self-harm. Have they previously gotten help, and is the home environment safe? Okay, yes, so yes, there were no concerns for safety of the home environment. He was spoken with alone and asked about safety at home. Had he previously gotten help? Yes, he had. And this problem developed 9 months ago. So that's one of the questions that I asked him. And he had been to 2 other psychiatrists at the time. One when it first started happening, and then one around the first of the year. And he had gotten prescriptions for some medications from both, but hadn't taken any of them because he was too nervous that it would make his symptoms worse. And so he hadn't taken any medications, and he was coming to the urgent care because he had finally reached a breaking point. Anything else that you all would want to know? Medication history and substance use. All right, I'm going to wait till any more. Okay, those are all the questions, the input so far. Excellent. Okay. So I asked him when the symptoms started. He said around 9 months ago. And then I asked him about, a little bit more. Tell me more about these episodes. Are you having anxiety all the time, rather, or does the anxiety come in fits and bursts? And he said, well, it's pretty much episodes. The anxiety comes on and it'll last a few hours. Sometimes it'll last a few days at a time, and then it seems to subside. But the visual snow is constant. I asked him if any triggers bring on the anxiety episodes, and he said, sometimes if I think back, I can, imagine an event, that might have brought it on, but it's not something that I would ever have worried about before. It's not something that I would ever have been anxious about, but it can set me off. And then he says, sometimes I just don't even know, it just comes on spontaneously, and I, unpredictably. And so I also asked him, and I didn't write it on this slide, well, what brought you in today? Was there anything specific about today? And what had happened was a few days earlier, he had gone to see an ophthalmologist about the visual snow. And his perception of that encounter, because I wasn't there, and so I don't know what was actually said, right? But his perception of that encounter was that he was told that that his visual snow was a neurologic problem, and that he was just going to have to ignore it, and that he should go see a neuro-ophthalmologist. And so, having experienced the encounter pretty negatively, in that way, he started becoming increasingly anxious, and then reached a point of complete overwhelm, and came to the urgent care. I asked him, what makes the anxiety better? He said, nothing. Time. I just hope that with time it's going to go away. So what makes it worse? He said, well, when I can't sleep because I'm so anxious, and if there's any added pressure, like I have schoolwork. He said his grades were really suffering, and he was very upset about that because he was a pretty serious student. And so having that added pressure was very stressful and made him more anxious. And then someone asked about substance use. Ding, 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 ding. There's $1 million question sometimes. Many times it's a confluence of information, that you get. But sometimes, in some cases, there's $1 million question, and it takes you where you need to be. And so I said, well, have you ever used alcohol or illicit drugs? Are you currently using alcohol or illicit drugs? And of course, I always, go through the list with people. But he very readily volunteered that he does not use alcohol or any substances right now. He is scared to death of using any substances. He had used marijuana on like 3 occasions in high school, like in the context of experimentation, but with really little effect, and hadn't used since. And then he told me that 9 months ago, he used LSD one time in an experimentation, just experimenting. He used a small amount of LSD one time 9 months ago. And so that's sort of where I get on the yellow brick road, right? And so I said, well, tell me more about LSD. He said, well, initially the high was, like pleasurable. It was nice, like I would have expected, but then really quickly it just turned really bad. He said he entered into an episode of severe panic-like anxiety that lasted for hours on end. And he remembers seeing a lot of floaters in his visual field. About 3 days later, after he used, he developed visual snow. And then about 2 weeks after he used, he started having these episodes of anxiety as described. All right, any questions now? one-time use of LSD can have this kind of effect? Yes, it can, and I'm going to tell you all about it, as much as I know anyway. Okay, that's the only question. All right. So after hearing the story, I was very excited that I had sort of gotten to the bottom of this problem. I mean, sort of, as much as I could in an urgent care setting. I had a potential explanation, right? Maybe not, but a potential explanation that made sense. However, I had not remembered this phenomenon, read about it, studied it in any way, anything since maybe medical school. So how horrifying, right? I mean, you have somebody in front of you, you're the doctor, you're supposed to know what to do, and you actually have no earthly clue what to do. So guess what? That happens. And it happens more frequently than you might expect. You are not a computer, you're not an encyclopedia. It's okay to not know. Because again, remember, what you learned in medical school was how to think critically, how to think on your feet, how to move quickly and efficiently and get the knowledge you need. And so it's okay to not know. A corollary of that, though, would be to know what you don't know. Also super important. If you don't know, you don't know. Recognize that you don't know and figure out whether it's a better idea for you to gain that knowledge, or it might even be a better idea for you to refer that person to someone who has that knowledge offhand. And so if you don't know what to do, don't panic, breathe, coming full circle to the beginning, take a deep breath, ground yourself, and you might even tell the patient, which is exactly what I did. I said, wow, this is something that I haven't thought about in some time, and I need some extra time to think about it. Is that okay? And they said, oh yeah, of course. I said, great. And I looked it up and I did an evidence review. Unfortunately, there's not a ton of evidence about this phenomenon, but I was able to find a beautiful meta-analysis that's fairly recent, I think from 2018 or 19, reviewing the available literature about an entity called hallucinogen persisting perception disorder. And so what this is a total or a partial recurrence of perceptual disturbances that appeared during hallucinogenic trips. These disturbances can reemerge without recent use and sometimes have a latent period of days, weeks, or even years. The episodes can be spontaneous or they can be triggered, which was the case with this man. They can be continuous or intermittent, like they were with this man. And so this man had some continuous symptoms, namely the visual disturbance, the visual snow, and then the anxiety experience was intermittent. This can occur even after a single exposure to the substance. Most frequently, the substance is LSD, but it can be other hallucinogens and even cannabis. This phenomenon can occur regardless of the amount of substance used. We don't know too much about the prevalence because it's so rare, but it's thought to be about 4% of users of hallucinogens, which is a pretty small number in and of itself. And so not too many people. And of those people, not many people come to clinical attention, right? Because in many people, this is a fairly benign experience where they might get a flashback of a previous trip, but it doesn't disturb them and they don't come for help. And so really the people who come for help are the most distressed people, and that really biases our experience of this phenomenon. We are only seeing one end of the spectrum typically in medical settings. How do we treat this? There's really not a great evidence base for treating this. And prognosis is also, because it's so rare and it's not, it's not very frequently documented, it's unclear what the prognosis is. And it's unclear what to do. And so there is some evidence for agents that are presynaptic alpha-2 adrenergic agonists, and like clonidine, which are typically used to lower blood pressure, but they also have an effect in the brain that can correct these disturbances. The benzodiazepine class of medication, also there's evidence that specifically clonazepam can be helpful. The anticonvulsants have some supporting evidence related to the idea that these episodic disturbances have a seizure-like activity in the brain, changes on EEG that might suggest, not exactly a seizure, but sort of. And then there's mixed evidence for antipsychotic medicines and the SSRI class of medicines. So yeah, a lot of mixed evidence, and it's just not really clear what the appropriate course of action is. Any questions before I tell you what I did and why? Okay, great question. So does visual snow actually happen, and would it be disorienting? And does one experience visual snow if dehydrated? Visual snow is an actual neuro-ophthalmologic phenomenon. People do describe it in exactly this way, of this sort of snowy, staticky like covering in their environment. For some people, it can be, worse in different kinds of light and in different circumstances. But yes, it's a real, it's a real perceptual disturbance. It can be disorienting for people, depending on the severity of it and really how impairing it was to their vision. Really would be qualitatively, it can be a little bit different, and so the degree of impairment can be different. I don't know if one experiences visual snow if dehydrated. That I'm not sure about. Isn't visual snow a coexisting symptom of migraines? Great question. So it can be. It can be a manifestation, typically like an aura prior to a migraine headache can have visual disturbances that might be similar to this, as well as all different other kinds of visual disturbances. And then there are migraine headaches that are themselves just ocular migraines that are ocular in predominantly visual, with maybe some actual headache afterwards, but sometimes even not. And so yes, does comorbidity of physical and psychological disorders make it very difficult to treat patients? It can. And so in an urgent care setting, and even in other settings, am I positive that this was the answer? No, absolutely not. And certainly there are other things that need to happen in this case. This guy probably has bought himself a head scan, to make sure that he does not have a brain tumor that might be causing this, for example. And probably an EEG to look for actual seizure activity, etc. And so, yes, often, physical and psychological disorders commingle, they co-occur, and it can be very hard to tease them apart. Great question. What do you do when you aren't able to figure out a cause for the patient's symptoms, but you still don't feel comfortable sending them home. If I think that the person is acutely ill and is not able to go home, that I would send them to the hospital for additional workup. And that's really the decision to make. Is this person stable to go, or do I have to put this person in the hospital? Whether it's because they're not safe or whether it's because their illness is so severe that they are, that they need more workup than I can provide in my setting. Is there any concern for prescribing another medication, especially benzodiazepines, to someone who experimented with illegal drugs? Great. I love that segue into my next slide. Take home point, never say never and keep an open mind. It can be very stressful to make decisions like this, specifically with regard to the question that was just asked. Do I really want to give a benzodiazepine to someone who's experimented with illegal drugs? Benzodiazepines are not my favorite class of medications, and I actually prescribe them very rarely. And when I do, I prescribe them very sparingly. And so that is definitely a concern. But I will never say never. So I'm not going to tell you that I would never prescribe a benzodiazepine to this person. I strive to always keep an open mind, and I would pass that along to you all as advice as a future physician. Keep an open mind, because sometimes what you wouldn't usually do ends up being what you need to do. And so in this particular case, here I had someone that was in very, very severe distress. And I guess if I haven't portrayed it that way to this point, I hope I have, but if I haven't, let me tell you again how distressed this guy was. And I had a good reason to believe that if I did not provide him immediate relief from these symptoms, that he would end up in the hospital. And so one of my goals for this encounter was to keep this man out of the hospital if possible. And so having said that, and another point that's important is that this man was now so worried about taking anything based on his experience with LSD that I didn't really have a concern that, especially in the short term, that he would misuse any medication I would prescribe, or overuse it or misuse it in any way. So there was that as well. I mean, there was also, he had learned a lesson from this experience, and it was very, very tragic. So I was not really worried in the moment that he might misuse a medication. So what did I do and why did I do it? I did go with the clonazepam, and I gritted my teeth as I did it, because like I said, I don't really like using medicines like that, but never say never and keep an open mind, because I needed to make him feel better, hopefully, in the short term. So I chose clonazepam because it's a long-acting benzodiazepine, and there was some decent supporting evidence for using it. And I figured it would give him some immediate relief. And that's what I was going for. And I wanted to avoid hospitalization. In the long term, I chose an anticonvulsant called lamotrigine. Now, I chose it because it does have some supporting evidence. But I also chose it because this was a man who was very reluctant to take medicines. He was very, very anxious about taking medicines, and that's why he had medicines prescribed to him, but hadn't even tried them. And for whatever reason, I don't know, there was an amount of buy-in from him around lamotrigine. I think that he had, used Dr. Google and had read a case report about complete remission and was very encouraged by that. And there was buy-in there. And so, whereas if there were no issues around buy-in, I might have chosen clonidine instead. But in this case, he was bought into the idea of titrating, starting lamotrigine and titrating it. And so I went with it, knowing that, in my back pocket, I could also, I could start clonidine in place of lamotrigine or in addition if I needed to. But this was a regimen that he was comfortable with. And so I needed to give him something that I could have, some degree of reassurance that he would take. And so this was it. That's what I did. Any questions? How long would this person have HPPD? And is this something he has to live with for the rest of his life? I don't know. I don't know. There is evidence of remission with medicines. There is some evidence of spontaneous remission. There's evidence for this being long-lasting and ending up being an illness, a condition that needs to be just managed. So I don't know the answer, but I'm approaching this with optimism that we can affect some change for him. And so my goal would be remission. My initial goal would be remission, and see what happens. Would prescribing some kind of medication for sleep also be considered? And so that was clonazepam also. And so that was killing a bunch of birds with one stone. That this would be, clonazepam would be an anxiolytic, and it would also help him sleep if he was having trouble sleeping. And then how much evidence from research would you need to be confident to prescribe / diagnose something new like this? Well, that's a great question. So that's interesting. I don't know how to answer that. I think that at this stage in my career, I benefit from reviewing evidence all the time, and I do rely on it in situations like this. But I also, having had experience, and again, medical school will teach you to think critically, and you will get the foundation that you need in medical school. I was able to extrapolate from the evidence, enough to feel fairly confident that I was doing the best I could with the information that I had about this person. At the end of the day, brains don't read textbooks, okay? And I know it, and I made sure that the patient knew it. And that is super important, to be completely, I tend to be forthcoming with patients and saying, this is not a tried and true regimen. There's some evidence for it. I feel confident enough to send you home with these prescriptions, but I can't promise that this will help. And I also can't promise that it won't hurt. I don't believe it will, I think that the potential benefits of this regimen outweigh the risks. And that is the essence of the decision. Do I feel like the potential benefits outweigh the risks? If so, then I'm going to do it. If not, then I'm not going to do it. And that's the conversation that I have within myself and then, with the patient, to make sure that everybody's on the same page about what we're doing and why, and what the potential benefits and risks are. So, was I successful? This is actually a case in progress, if you will, and so I don't have, I only have one additional time point. But what is really important, again, going at process over content, is really understanding and knowing what your definition of success is. When I see somebody for the first time like this, and the person is distressed, and the person has interacted with the mental health system on other occasions and hasn't followed up with the person or the treatment, one of my primary goals is for them to come back. I really want them to engage with mental health, and I want them to feel okay, you know, at the minimum doing it. And so what's your definition of success? I really wanted him to come back. So, and I wanted him to stay out of the hospital. So did he stay out? Yes, he did. Did he come back for follow-up? Yes, he did. Did he experience some acute relief from clonazepam? Yes, he did. He did, the way he described it was his anxiety did not get alleviated as much as he might have expected. But for the period that he took the clonazepam, now he only took like 2 doses because again, he was very anxious about taking medicine. And so, but in the time that he took clonazepam, the visual snow actually resolved. So that was a positive outcome, and as well as some anxiolysis. And at the follow-up, I encouraged him in this short-term period while we're titrating lamotrigine to feel okay taking a little more clonazepam if that is helpful for him. And is he on board with the long-term plan? Yes. So we did a staggered start. I asked him to take clonazepam for acute relief first, for the first 3 to 4 days. And if he tolerated that well, to start the lamotrigine. And that is typically a rule of thumb that I follow, take-home point that I didn't make a slide for. I very rarely, never say never, I very rarely start 2 medicines at the same time, because if one of them really works or if one of them really doesn't, if you start them together, you don't know what caused what. And so I stagger. And so he did clonazepam for acute immediate relief. Once he was comfortable that he could tolerate clonazepam, that it wasn't making any of his symptoms worse, he began to titrate lamotrigine and tolerated that very well and was on board. The last take-home point is don't be afraid to ask questions. And so does anybody have any other questions for me? One question is, what would you say to people who plan on experimenting with drugs, and how would you stop them? Well, you can't stop them, in my experience, but you can deter people. You can help, you can start the dialogue. I think that especially, adolescent brains are adventurous brains, and really, I seek to educate people non-judgmentally. And so, I feel compelled to, come home, or any young person I see, tell my kids or other kids, like, don't do drugs, don't start, you feel compelled to just scream at people and shake people, don't use drugs, don't experiment with drugs. But that doesn't work, right? That does not work. And so education in the home, earlier than you think you need to ask those questions and have that talk. At the school, everywhere. And have I encountered cases of spontaneous remission in my work? No. And in fact, I don't remember the last time I saw this, to be honest. So, Any other questions? Do I recommend therapy for patients in conjunction with a prescription for medication? And if so, which types of patients do you find benefit most with therapy? People benefit most from therapy if they are willing to engage with therapy. And so sometimes the interplay with medications and therapy is that medications make somebody a better candidate for therapy because they take the symptoms down maybe from a 10 to a 7, and that's enough to allow the patient to engage with therapy more effectively and more beneficially. In this case, absolutely, I would recommend therapy to this patient because this patient had developed the anxiety in addition to being sort of, I don't know how to say it, organically generated, if you will, by this phenomenon of HPPD. It also, there's a propensity for anxiety to take on a life of its own, where he was now beginning to have some anticipatory anxiety, like I am anxious about becoming anxious, and the anxiety can sort of spin and sort of spiral out of control, and that's a really good target for psychotherapy, of challenging that anticipatory anxiety, and also learning coping skills for managing anxiety is key in a case like this. And so absolutely, I would recommend psychotherapy. Are there times when I feel that prescribing medication isn't the answer? And then do I refer the patients to different physicians? All the time, all the time. I collaborate with other specialty physicians. I collaborate with therapists. I am also a trained therapist. And so as a psychiatrist, I don't, my focus isn't always medication management. In the urgent care setting, it tends to be, but in a private practice setting, in my outpatient setting, I do psychotherapy probably more often than I prescribe meds. What does a patient follow-up look like in an acute care setting, like an urgent care? Do you meet with them in a separate outpatient setting? Yes. And so the goal would be to shift this patient's care to the outpatient level as soon as I can. Sometimes that's not possible. If I wanted to see them back in a week or 2 weeks, chances are they wouldn't be able to get an outpatient appointment. And so in the urgent care, we will follow up with patients, at whatever frequency is indicated until they establish care. Do I encourage techniques to activate the parasympathetic nervous system as an adjuvant to medications? Yes. And so, and I am an active proponent and practitioner of mindfulness meditation. And in fact, that's what I did before I started this talk. Is I did a brief awareness of breathing meditation, and I use mindfulness all the time, and I teach it to my patients. I said that HPPD can also develop due to marijuana use. Are the symptoms similar to HPPD after LSD? Yes, and synthetic marijuana is particularly an offender in my experience. Yeah, I think that's all the questions. There were some questions at the very beginning, and if we're out of time, I will skip those. Otherwise, I'm happy to address them.
It's up to you. You can go over them if you'd like.
Okay. I mean, are people still here?
Yeah, they are.
How do I manage my own mental health within this particular field? I've heard that it can be mentally taxing. I love this question. I saved it to last because, because it's sort of another conversation. But yes, I manage my mental health in a number of different ways. And so at different times in my career, I have had my own therapist, and that is really important for people who are therapists to also engage in therapy. I also have a support network of other psychiatrists who I train with, or who I know from my area, and with whom, and also some psychologists, and we can get together and bounce ideas off of each other. We can process difficult situations. And so really finding support around you is key. The other two things that I would like to mention about this is developing certain self-care practices that will support you as you support other people. And so I already mentioned mindfulness being a pretty important one for me. And I use it early in the morning and throughout my day. And it's a way that I can really stay present with whatever situation I am in. And so that's really important. And there was one other thing that I was going to talk about. Yes, keeping one foot in the door and one foot out. And that's a sort of, I don't have an easy way to explain how to learn to do that. But it's a skill acquired over time. And it's, being able to, whenever you're in a room with somebody, always have one foot out the door and one foot in. Because only if you have one foot out can you have the objective distance to help the person. And only if you have one foot in can you really connect with that person and find compassion for that person and put yourself in that person's shoes. And so, but both are key. One foot out, one foot in. One foot out also allows you to leave your work at your work. And so I always picture myself, like when I leave that building, it's as if all the things that were told to me and that happened that day are in a big pile and I put them in the trash. And I go home as me, as myself, and sort of less as Dr. Spessot, but more as just, human being, mom. And I kind of take my doctor hat off after that. What is it like being a mom and a physician? It's hard. It's so hard. How do you manage both? And what's a typical day in my life like? It is hard. I'm not going to lie. I think it's important for physicians not to lie and not to put up the appearance that it's, great because we're all so super efficient, right? No. Yes, we're efficient. But no, it's not easy. And it's okay to ask for help. It's okay to not be okay. A typical day in my life. So today, I woke up at 5 in the morning. I wake up at 5 during the week. I did some yoga and I did some meditation and I did some affirmations and visualization exercises. And that's my typical morning routine. And then at about 6 or 6:10, I start getting myself ready for my day. At 6:30, I wake up my 2 older children. They come down. I pack the 3 children their lunches. My 2 big kids bring, we have 3 dogs. And so they each sleep with a dog and then one sleeps with me. And me and my husband. So we have, 3 dogs. They come down, they feed the dogs. They feed themselves breakfast and I help. Then they take the dogs out. By this time I've finished with the lunches. I go wake up my 3rd child who's younger. I feed him breakfast. Then we all scramble like chickens with our heads cut off for 10 minutes until we're all ready. Do you have a mask? No, I didn't have a mask. All the things, because thankfully they're back at school, but we need masks. And we kind of just chaotically scream at each other and make sure we haven't forgotten anything for a good while. And then we all get into the car and we drive to school, and they go to 2 different schools. So I make that drive, and something always happens, during, the car ride, like somebody forgot their mask and we had to, find one, and, something always goes wrong. I do a drop off. Then I drop off the dogs on the days that I see patients, or I do something like this. I take them to doggy daycare so that they don't lose their minds, while I'm working. And so I took them, and then I brought my youngest child to school, and then I came back to my home today. I'm not in my office today. And I started my day. Start my day around 9. I work like a chicken with my head cut off until about 2:30. And then I go get my kids and we scramble around a bunch. And then I work out. And then I cook dinner. And then my husband comes home and then we scramble around some more to get ready for the next day. And then the kids go to bed. And then he and I have some, time together, a couple of hours together where we will do something, together, watch a movie, play a game, do crossword puzzles, or just, zone out, like, just veg out. And then we go to sleep and then I do it over again the next day. That's my day. It's not easy, but it works. And there are definitely ways to make one's life easier, which I would wholeheartedly recommend. And the key is figuring out how you can make your life easier. Like I have a cleaning crew come to my house every week. It's kind of a non-negotiable because with the free time I have, I'm just not gonna be able to, well, that's not true. I could clean my house with the free time I have, but I choose not to. What pushed me to psychiatry or surgery? For colleagues that were between psychiatry and surgery, what pushed them to either side? Those specialties seem very different, but interconnected as well. I'll tell you why I didn't choose surgery. And for a little bit, it was kind of a painful story, but true. And it's important for us to share why we made the decisions that we made. My brother's an anesthesiologist and he was an orthopedic anesthesiologist at the time. And so he was like, well, come to my hospital and, talk to, the orthos and see, talk to them about their life. And so I went and I found every female orthopedic surgeon I could find. And I said, what's your life like? This is when I was in medical school. And they were like, it's great. I love being a surgeon. But the theme was, you need to get a really good nanny. And that gave me some pause, not because there's any judgment there around having a nanny. And Lord knows I've had multiple nannies. But the underlying message was that I might not have the kind of free time that I value, and that I might not have the opportunities to be with my children the way that I would value or prioritize. And so I made the decision to leave surgery alone, not pursue surgery, because I was concerned that the lifestyle would feel all-consuming to me and that I wouldn't be able to engage in other pursuits that I also appreciate. And so that's why I made the decision. But I think that there's a very common thread between surgeons and psychiatrists, and that there's an intensity to what we do that makes us, it's the ability to really become intimately acquainted with our patients and to really experience human beings sort of on the inside. Am I practicing in telehealth now due to COVID? Yes, I am. And so I have a telehealth. I can do telehealth from my home here. This is my home office. I do have a brick and mortar office though for my private practice. And I do like going there because for me, the act of going to work feels important. And so I kind of split my time between my home office and my brick and mortar office. My husband is also a physician. He's also a psychiatrist, actually, and that was not planned. And so he actually does telehealth from home 2 days a week. So when he's here in this office doing telehealth, I make a point, obviously, to not be here. And so we kind of split the time. How does having mental illness affect doctors' experience in med school, residency, and the workplace? And are there structural barriers or interpersonal stigma? Yes. Structural barriers, interpersonal stigma. I think that it's an absolute tragedy that physicians who struggle with mental illness feel that they can't come forward with this and get treatment for these conditions because of the stigma. I think that, I don't know the statistics, but I'm, offhand, but I'm pretty sure they're pretty profound. If you look at how many physicians experience clinical depression, I think that percentage is really high, especially in residency, because residencies can be a really difficult time. And so I think that it's the stigma is very real, and the way to combat it is to do this, and to speak out against it as much as possible, and to give other physicians just the message, whether it's overtly or even covertly in read between the lines sort of ways, like, hey, I'm here, hey, reach out, give a call, let's talk about getting help if you need it. One of the lines that I find myself using just so often with like everybody, like with families, when they're talking about, well, should my child take this time off, they're going to be missing school, like, to get this therapy. And my question to them is, if this were a kidney problem, would we be having this conversation? No, we wouldn't. If you had broken your leg and you were like needing physical therapy for 12 weeks in order to be able to walk again, would we be having this conversation? No, we wouldn't. So this is just an illness of the brain like any other. We have to treat it that way. Well, I think that's the last question.
Yep, that seems to be all of them. Thank you so much, Dr. Spessot, for a wonderful in-depth presentation and for answering all of our questions. It was an honor to learn from you.
Oh,
Everyone,
thank you so much.
Please make sure you check out her socials to learn more from her. Her Instagram is @theconnectedmd. The link to today's Google form has been posted in the chat box and will be in the description of the video shortly. Please fill it out within the next 30 minutes for us to receive verification of your attendance, and we hope to see you all at our next session.